right, so this is a talk on Lvad. Lvad means left ventricular assist device. Ventricular means the lower chamber of the heart. And to give you perspective, this is the heart in somebody that has no need for an Lvad. Notice it's sort of a conical shaped left ventricle. And this is the heart of somebody who needs an Lvad. Notice the difference in diameter. The shape is more circular, and the leaflets of the mitral valve may also be leaking quite a bit. There may be a gap there, and you may have a vast amount of leakage here too on top of that. But the bottom line is that the power generated by this heart right here is probably 65%, which is totally normal. And the power generated by this heart right here would probably be in between 15 and 30%. Closer to the 15%. It's a big difference. So to give you perspective, if you're a marathon runner, you need this heart. Okay? If you play tennis, you need this heart. If you play tennis with your grandfather, you may get away with 30% EF. What will 15% EF give you? It'll give you washing the dishes with a little bit of shortness of breath as you walk from the sink station to the chair. That's not a good life. That's effectively drowning with activity. So the idea behind an Lvad is that when you have a heart like this heart, the muscle, is gone. It's still present, but it's not contractile. That muscle will not be moving, will not be generating forward flow, and the person needs to have forward flow to stay alive and feel well. So an Lvad renders the left ventricle obsolete, in essence, because what it does is it drains the blood out of the left ventricle and propels it to the aorta, which is the main highway. This is the aorta. This is the main highway of blood outside of the heart to the rest of the body. And this here is called the aortic valve. That's the aortic valve. So what do when we implant an Lvad? It's important to remember that right now, as it is 2018, we don't have the technology approved by the FDA of a pump that is 100% implantable without external parts. We still have a connection to the external world, which is called a drive line. And so if this is the aorta and the heart is here, remember, very big heart, very big left atrium, mitral valve. The idea of an Lvad is that during open heart surgery, this is open heart surgery in every sense, we're using the heart-lung machine, which is a pump that circulates the blood to keep the patient alive so that we can then stop the breathing mechanism. And the heart may or may not pump. It doesn't matter because the body keeps getting blood flow. But the idea is that once we're on the heart-lung machine, we can actually create a hole here in the heart and cut a plug out. And within that plug, we put in, or we sew in, a cannula. A cannula is nothing but a fancy name for a tube that acts as a drainage for the blood. That connects to the pump. Nowadays, our pumps are very small. They're very, very small. Literally, that's about the appropriate relationship of a pump to the heart. And that pump has an exit cannula again, so the blood gets drained this way. It's centrifugally pushed to the side to a graft that the surgeon then hooks up, or anastomosis, right here to the aorta. Okay, so this is a suture. So in essence, the blood will then be drained through the cannula, centrifugally pushed through this graft into the aorta, where it will go everywhere in the body to keep the patient alive. The normal human heart, or the normal human body, requires on average 5 liters per minute of flow. These pumps can flow easily 5 liters per minute, if not more. So these pumps supply the body with all the blood the body needs. Even if the heart were completely static and not mobile, the patient would still be alive. But it's an important part that often gets neglected when we talk to patients about LVADs, is that where does the blood in the left ventricle come from? It comes from the lungs, through these little tubes that are called the pulmonic veins. Two for the left, to the right lung, two for the left lung. The blood comes in. This blood is rich in oxygen, just came from the lungs, and it travels down here and then gets sucked by the pump and pushed forward to the aorta. But where does the blood from the lungs come from? Well, it comes from the right ventricle, which I will draw here. And this is the tricuspid valve, and this is the right ventricle. This is the right atrium. So the blood here in the right ventricle gets pumped through an artery that I don't have space to draw here, but it's pumped through an artery called the pulmonic artery to the lungs. That blood is low in oxygen, rich in nutrients, because it also comes from the gut. If you just ate, it carries all the nutrients. And in the lungs exchange the carbon dioxide for oxygen and all that, and then the blood returns clean with oxygen to the left atrium, to the left ventricle, to the pump. So, what are the weak points of an LVAD? The right ventricle. If the right ventricle does not pump, there will be no blood getting to the lungs, to the left atrium, to the left ventricle. So it's very important that when one assesses a patient for LVAD, that the right ventricle be healthy or as healthy as can be. More often than not, the right ventricle, in most of the patients that we deal with, has some degree of dysfunction. And so during and after surgery, oftentimes we have to help the patient, not just for the pump. The pump will help the ventricle, but we need to help the right ventricle with medications. So it's not uncommon that patients come after surgery with 2 or 3 medications to support that right ventricle for a few days. It can be a couple of days, but it usually is 4 to 5 days. In the extreme of cases where the right ventricle, so to speak, just tires out during the operation, it can happen, then we have mechanical devices that are temporary that we can put in through the groin or through the neck that sit within the ventricle, the right ventricle, to propel the blood forward. And those 2 devices are very useful and can help the ventricle recover in 4 or 5 days. We've seen that too. So it is important when talking about left-sided heart failure never to forget about the right side. If you are a very healthy person otherwise and just had your heart poop out on you, so to speak, one day because you had a heart attack or an arrhythmia or a viral infection, which is also common, you go to surgery and you stay in the ICU for about 5 days, 6 days, and then you go to the floor, and in 10 days you're home. That's a good day. That's a good case. We've had that. We see that. But more often than not, we see the patient who came to the hospital with a big heart attack, never recovered, did really poorly, is very sick. The right side may be tenuous, but not terrible. And their course is in the 20 to 30 days in the hospital. They're malnourished because they've been 15 days before we even got to them. They may have been 15 days in a hospital, 10 days in a hospital, with a balloon pump in their groin, doing poorly. So we see that too, unfortunately. One of the 2 pumps, there are 2 approved pumps by the FDA. One is called an HVAD by Medtronic or Thoratec, or not Medtronic or Heartware. And the other one is the HeartMate 3, which is by Thoratec, also Abbott St. Jude. And those are the 2 pumps that we implant nowadays. The HeartMate 2 used to be our workhorse because it was the only thing approved by the FDA for patients with heart failure that were not candidates for transplant. Now we have, well, the Heartware, the HVAD, is approved for destination in somebody who's not a candidate for transplant. And the HeartMate 3 currently is only approved as a bridge to a transplant. So our workhorse right now is the HVAD, and in selected patients we use a HeartMate 3. Both are good pumps, very good pumps. Your question, is there something in the docket by any of the companies? So the HVAD company wants us to think that they have something, not submitted to FDA yet, because there hasn't been any clinical trials, but by their engineers, that will be totally implantable in 5 years. So in 5 years, it leaves the bench and makes it to the bedside for clinical trials, feasibility trials. So a year later, it becomes a clinical trial where we enroll patients, let's say 2,000 patients to do this. Then 3 years after that, now we're at 4 years, plus the 5, then we have a pump that then now has data to go to the FDA. It's 10 years. Best case scenario. So there, yeah, it's so many things. So to control this pump, this has the drive line that exits usually the right upper quadrant, right under the rib cage. And that not only carries electricity to the pump, but also controls the speed and receives the information from the sensors in the pump about, the thickness of the blood, the density of the blood, and how much RPMs are needed to propel the blood, all that. It's a very complex algorithm for any of the pumps. So this drive line is really what is the biggest problem in terms of being totally implantable. You could argue that the data can be streamed. That should not be a problem, but electricity, that's a different animal. And I know companies have worked in Palo Alto to have a transcutaneous charger, much like the phones, right? So it's underneath the skin. You have a plate. You put another plate on the outside that transmits electricity transcutaneously. You charge your pump that way. That is in the works. But even if it was something that you would have to carry with you, with an external battery, the fact that nothing gets out of your body would prevent problems like a driveline infection at the site where this comes out, which is tremendous. It can be devastating, a driveline infection. So we'll get to that part probably within the next 10 years. But it won't be like a pacemaker that you can put it in and forget for 10 years that it's in there.